Good afternoon, everyone. I'm delighted to welcome you to this IndOx hosted webinar with Professor Sandra Albert and Dr. Rajiv Sarkar from the Indian Institute of Public Health in Shillong. I'm very pleased to call Sandra and Rajiv my collaborators, but also my friends. And we have worked together previously on trying to develop some research projects focused on the healthcare needs in the northeast region of India. Sandra is the director of the Indian Institute of Public Health, and Rajiv is an associate professor there. And I'll let them tell you a little bit more about themselves. So the format that we're going to use today is we're going to have a short presentation from both of them, and then the three of us will have a little bit of a structured conversation, and then we'll open things up to the attendees. If you have any questions, then please share them with us in the Q&A chat box, not the chat box, the Q&A button at the bottom of the screen. And when we open up to questions, you can raise your hand and we'll be able to unmute you and you'll be able to ask a question. Okay, so that's enough from me. So I'm going to hand over to Sandra first from the Indian Institute of Public Health.
Thank you very much, Toral. Can I ask Marwa to do the first slide? Apologies if in case my connectivity acts up. I am on a slightly weak connectivity, but let's hope it goes well. Marwa, first slide, please. Can you go to the full screen mode?
Could view in this a slideshow.
I've started the slideshow. Hopefully, it should.
First, it's under. It's kind of on. Should I start?
I think just give them all a second.
Okay.
Oh, here we go.
My sincere apologies about this.
That's all right. Okay, Marwa.
Yeah.
I can share it.
Oh, has it worked?
Oh, yeah. Fantastic. Yes, it did work. Thank you.
Great.
Thank you. So sorry about everyone about that. And greetings from the Indian Institute of Public Health in Shillong, particularly from the Northeast region and Meghalaya. Over the next few minutes, what I thought is I would tell you a little bit about our place, our people, and a little bit of the centers of research that we have, and then hand over to Rajiv. Next slide, please. So for those of you who are not familiar with the Northeast region, we are 8 states together bordered by Bhutan, China, Nepal, Bangladesh, and Myanmar, which means this region of the country has about 98% of its borders are international. It is a landmass above and beyond Bangladesh, connected to mainland India by what is often likely called the chicken neck strip of land. We have myriad tribes and ethnicities, and depending on which statistic you follow, anything between 200 to 400 languages. We are a biodiversity hotspot, the whole of the Northeast region, in fact. And coming to Meghalaya itself, Meghalaya is kind of the roof of Bangladesh. We have a population of a little over 3 million. And largely what in India is referred to as scheduled tribes belonging to the Khasi, Jaintia, and Garo tribes. The tribes of Meghalaya, the major tribes of Meghalaya, are matrilineal. What that means is children get their maternal clan names, the youngest daughter inherits ancestral property, and the birth of daughters is celebrated. We do not have a caste system unlike other regions of India. Next slide. This is mainly an agrarian economy. Meghalaya has a fair literacy rate, and the women seemingly have decision-making powers in households. So these are usually reasons that are often cited as indicators of good health in low and middle income countries. But I refer to this as the Meghalaya paradox, because we do have some powers, but then this is contrasted by poor maternal and child health indicators, such as high maternal and infant mortality, high prevalence of stunting and wasting of under 5 children, high micronutrient deficiency in women of reproductive age, high fertility rate, especially rural fertility rate, high unmet contraceptive needs, teenage pregnancies, and so on. So that kind of seems to be a little bit of a paradox. Next slide. Just to contrast this and put this into perspective, if you look at Kerala, which is one of the best performing in terms of health indices, a southern state in India, where you can see the contrast between the infant mortality in Kerala and Meghalaya here, where Meghalaya's rural infant mortality is 33 compared to Kerala's 5. Next one. So I suppose to keep things simple, in the COVID-19 pandemic actually highlighted the importance of public health system strengthening and the value of public health training and research to the world at large. India, including the Northeast region, continues to be confronted by the double whammy of infectious diseases and other allied other conditions such as nutritional deficiencies, so on, while also having to deal with the emerging and escalating problem of non-communicable diseases, particularly cancers. So there is definitely a persistent need for looking into preventive aspects of all these conditions. And in some sense, our institution was set up as a regional institute to address the paucity of institutions to deal with training, research, and advocacy in public health. Next one. So one of the first centers that we established was the Center for Study of Complex Malaria in India. Meghalaya is endemic for malaria, especially the Garo Hills region of Meghalaya. The CSCMI was a collaborative initiative with New York University and researchers from a host of other institutions, both international and national. And this is one of the 10 international centers for excellence in malaria research. That's the ISMA initiative of NIH USA. And one a key factor here is that the focus is not just on high quality research, but also capacity building of young researchers from the region. Next one. So as part of the CSCMI's activities, there's a lot of things that's been happening. I won't go into the details. We did set up in 3 districts, particularly selected PHCs in 3 districts where malaria was endemic. And we set up these clinical and community level epidemiological studies. But much of this has already been published in literature, so in the malaria journal specifically. So if anybody's interested, they're in open access journals, so you could just look at them. I'm not going into the details of these. Next one. So this year, the CSCMI activities, we are going to actually focus on entomology studies. And that's using both morphological and molecular level identification of the Anopheles species. This work, in fact, is mentored by Kathy Walton from the University of Manchester. And one of the things we have been able to identify is that a new vector, namely Anopheles zooey, which was not previously reported in India. And there are others too. And so having seen this in our initial small-scale studies, we're going to focus a lot more on this aspect in this coming year. Next one. So one of the challenges was one of the words used in the title of the session, and I thought nothing better to show you some of the challenges that fieldwork in this area and terrain holds. I think it's self-evident from these pictures. We have issues of accessibility, poor roads during the seasons or the rainy season. some of our villages get cut off. We have to, when we are doing field work in our place, we got to deal with traditional governance institutions and take their consent. So it's an additional level of consent. And of course, you have to work with people at their convenient time. And so sometimes, field work has to happen at night. Just to give you a few examples of the challenges. Next one. So moving on from infectious disease, so the other second center that we have established is a regional resource hub for health economics or health technology assessment. This is to do economic evaluations, cost effectiveness analysis, and these studies are generally done for the public sector, particularly for the Ministry of Health and Family Welfare, who has funded this initiative. We have several ongoing studies in various states in the Northeast region happening at the moment. But I think I can just flag one particular study which got published in PLOS One just last week. This was our first study from our evaluation of the Mega Health Insurance Scheme, which is Meghalaya's health insurance scheme, which aspires to be a universal health coverage scheme. Next, please. Responding to the health policy which came out in 2017, which advocates for the creation of a public health management cadre for the nation, and being a federal system that we follow, the states have to take up the policy and implement it. In response to this policy, we started and initiated our Masters in Public Health program in 2019. This is just a distribution showing of our students so far. Of course, we cater largely to the Northeast. Over 70% of our students are from the Northeast region, but we were quite surprised to find that we were getting students from across all those states that are colored in the map are states from which we have students currently with us. Next, I think that we're almost there, close to the last slide. Okay, so I will close with this to say that just a flag, last year we launched a Bachelor of Public Health, and this again was a response to a need in the state. What we realized is just 12 to 17% of our graduates who pass class 10 get a chance to go into science streams. This, if you must remember Kerala, I mentioned Kerala to you and some of the southern states which are often considered more developed, like Tamil Nadu, Karnataka, Kerala, Maharashtra, and others, where the science STEM subjects are, up to 70 to 85% of students take. But in Meghalaya, it's barely 12 to 17%. And so we realized we needed to respond to this. And so we offer a bridge course for students, and then as part of the Bachelor's in Public Health, making it a little bit more accessible to those who want to enter science streams. Next, please. And I think that's about, I'll close there. I am happy to take questions now, Toral, if required, or maybe Rajiv can come in now and tell us a little bit more about our research.
I think let's go with Rajiv's presentation now, and then we'll come back to questions. I'm just checking, there's no questions in the chat at the moment, but I'm sure people are thinking of them as we are going. So Rajiv just messaged to say that he'd lost power. The title of the presentation being apt, I think, today, The Challenges of Research in the Northeast. Rajiv, is power back on? Are you?
I can see him, so I guess it is.
Yeah, he is. Let's unmute.
Power is also using my mobile internet connectivity, which may not be as good as Sandra's.
So shall we do the same with Marwa showing your slides?
Great, thank you very much.
Okay.
So I think this is a live demonstration of the challenges of
exactly
working in the Northeast, for that matter. Anyway, so next slide, please. I'm just going to quickly move on. Dr. Sandra did mention about the uniqueness of the Northeast and Meghalaya in terms of the biodiversity, in terms of the majorly tribal population, in terms of the unique climatic characteristics. Can I have the next slide, please? So I'm going to talk about some of the research studies that we are doing in IPH Shillong, and considering the characteristics of Meghalaya, the unique biodiversity, and also the fact that COVID also taught us about the threat of the zoonotic diseases, and taking forward our work on malaria, we did apply for and we did get funded from the DBT Wellcome Trust India Alliance, which is an organization part funded by the Department of Biotechnology, Government of India, and part funded by the Wellcome Trust UK, to set up a research and training center on zoonotic and vector-borne diseases. Uh, the center aims to bring together a transdisciplinary group of researchers to address the key gaps in zoonotic and vector-borne disease epidemiology in the Northeast, but also being a research and a training center. This will hopes to strengthen the public health ecosystem in the Northeast. So that is something that we have started this year in terms of the activities of the center, and we look forward to working towards answering some of the questions as well as capacity building in terms of laboratory, public health, and veterinary epidemiology in the region. Next slide, please. Other than that, we have been working on cancer. One of our faculty, Dr. Eliza Datta, who is an assistant professor here, she is an early career fellow from the DBT Wellcome Trust India Alliance, and she works on cancers. So she did submit a proposal on the epidemiology of gallbladder cancer, which has now been accepted, and she has started the work on it. And the uniqueness of gallbladder cancer is that it is rare in most parts of the world, but in the Northeast region, this is supposed to be one of the common cancers, and that is because of certain unexplained modifiable risk factors, but potentially because of environmental and exposure, as well as genetic susceptibility. And Dr. Eliza's project actually sets to explore the environmental and genetic determinants of gallbladder cancer in this region. Next slide, please. So the objectives of the study is to start off with conducting a systematic review and meta-analysis to identify the risk factors of gallbladder cancer, but also to study the determinants of association between environmental genetic factors of gallbladder cancer, especially exposure to pesticides and heavy metal, and look at SNPs to identify SNPs specific for increased risk of gallbladder cancer through a gene environmental interaction study. Next slide, please. We have also very recently done a situational analysis to understand the influencing factors to address delays in cancer care in Meghalaya. That is because, again, Northeast region is one of the places with a very high incidence of cancer, not only in terms of the disease incidence, but also in terms of delayed healthcare seeking, resulting in high mortality rate. And this is a study that was funded by the Indian Council of Medical Research, with Professor Sandra Albert being the principal investigator, to look at the existing program, which is the National Program for Prevention of Controlled Cancer, Diabetes, and stroke in Meghalaya, to see how the program attempts to do work for reducing the burden of cancer in the state, but also to look at individual and community factors related to delayed healthcare seeking in the state. And it is largely a qualitative study looking at in-depth interviews and focus group discussions with patients and other stakeholders to understand the healthcare scenario in the state. The next slide, please. So the initial results of the study, which was just completed earlier this year, was that we found there was a low awareness among cancer and also a sense of fear and stigma in the community, because cancer in this community is associated with death because of the lack of proper healthcare available in the region. They have to go to a central part in India, to another state in India for treatment, and that is also one of the reasons for delayed healthcare, because financial constraints are because of the fact that you have to arrange for money for treatment to go to other state, take someone with you, and so on and so forth. But there was also misconceptions and wrong belief, because the major source of cancer in this region was found to be friends and relatives who are non-medical people. And there was also a sense that cancer was related wrongly with communicable and other incurable diseases. And there's a lot of faith in traditional medicine, also possibly because of the lack of availability of health infrastructure in this region. So we are looking forward to work more on these domains in cancer. Next slide, please. Other than that, the Indian Institute of Public Health Shillong supported the government of Meghalaya during the COVID-19 pandemic, doing such different studies for them. One study during early on in the pandemic done by the team at IIPH Shillong was to look at the knowledge, attitude, and practices to hand hygiene, respiratory etiquette. This was done way back in May 2020, just at the beginning of the pandemic, covering a sample size of 416 participants in 3 districts, East Khasi, West Jaintia, and the Riboy district. The next slide, please. And while we found that there were certain changes, positive changes in behavior, for example, people would wash hands more frequently than they would during the pandemic than they would do before that. There was also a delay in healthcare for other illnesses than COVID, or possibly because of the lockdown and the fact that many of the government centers were transformed to a COVID healthcare center. That could result in delayed treatment as well. Next slide, please. What we also found interestingly was there was a lot of fear, stigma around COVID and surrounding COVID patients. For example, there was a thought that people who are coming from outside would bring the COVID in the community and so on and so forth. And there was, and these fear, stigma could result in backlashes for people coming in and from like travelers or returnees. And that was something that we found. Even there was some sort of apprehension of doctors and medical people because they would go to the hospital and come in touch with the COVID patient and so on and so forth. This is the manuscript which we have submitted and hope that this will come out soon. Next slide, please. We also did a study on COVID vaccine hesitancy because in Meghalaya was one of the states where there was a lot of vaccine hesitancy that was initially reported for COVID-19, and people were not willing to take, even though the vaccines were available and largely free, provided by the government. So we did a mixed method study looking at healthcare workers and the general population, and also focus group discussions of the ASHA workers and the interviews with people who tested positive, who did not take a COVID-19 vaccine, who refused a COVID-19 vaccination. Next slide, please. What we found was that the reasons for vaccine hesitancy was largely very similar between the healthcare workers and the general population, with not having a trustworthy source of information, being worried about the side effects of vaccination, and social media messages being one of the things that people felt was most important factor for them not going for the vaccination that was being provided. Next slide, please. We also later last year, actually, we did a statewise, supported the government and did it with the IDSP team to do a statewise sero survey for estimating the COVID-19 infection prevalence in Meghalaya. And we found in this study, which was covering 84 PHCs, which is almost 50% of the PHCs in the state, in all 11 districts. And this was done in October to December 2021, just before the latest strain, hit the Omicron wave hit the country. So just pre-Omicron, so the rates would definitely have gone up. We found an overall seroprevalence about 44% in the state of Meghalaya. So that is another study that we did in support of the government. Next slide, please. So in brief, these are some of the activities that we have been doing as a part of the Ministry of Public Health Shillong. Therefore, of course, there are other activities and studies that we are involved in, and but this is kind of some of the work that we are doing here. Thank you very much, and I'll be happy to take questions.
Thank you both, Sandra and Rajiv, for giving such a comprehensive overview of what the kind of work that you're doing, the excellent work that you're doing in that part of India. So kind of leading on from that, I'm kind of interested to know from both of you that, and Sandra alluded to this kind of double burden of disease and the epidemiological transition between communicable disease and non-communicable disease, that over the next 5 to 10 years, what would you both see as the biggest emerging threats to the health of the people in the Northeast region, and how different are they to the rest of India? So Sandra, maybe we go to you first.
Okay, so I think emergent is one side. The emergent burden is certainly non-communicable disease, particularly cancers, because we still have huge numbers of people still using tobacco and tobacco-related products. So it's a preventable risk, but we know that happen, and the burden is huge. They start young, school children are smoking, and we really need to get that that aspect sorted. Then, of course, there's non-tobacco, use, non-smoke tobacco use, and in various forms, and the traditional practices, more relative traditional practices like betel nut, quit chewing, and likes. So that's the non-communicable disease aspect of it. I think mental health will always be something which will grow. So that's again another mental non-communicable aspect. We still have Meghalaya in particular, and a few other states in particular, still has to get our maternal and child health, indices sorted. I think there's been a tremendous push now in the starting last year, in fact, the Meghalaya's health policies acronym MOTHER, because just to demonstrate that from all aspects we are conscious of it and wanted to look at it. So several things are happening in the state, all of which are fantastic initiatives, when we hope that aspect will get sorted out and improve. That's both early childhood nutrition, maternal well-being, and all the likes. That's a lot of that. The maternal health also involves the health system strengthening. So some of these initiatives are happening. But then the third thing, when you say the word emergent, always, we tend to think of infections. And I must say that almost every year we do have epidemics, outbursts, which is hardly heard in the national news. For instance, a couple of weeks ago, we had an outbreak of African swine flu. And so things like that come. We are in a biodiversity hotspot. We are at the interface of human, animal, environment interactions. We have cultural practices which makes these much more easy to cross animal into human. And so in some sense, the Zoonotic Vector-Borne Disease Research Center, what we're trying to do there is focus on 6 diseases for now, but we know we will be looking at more as we go on, because that's certainly something that we need to be paying attention to.
Thank you, Sandra. And Rajiv, if you have anything to add to that?
No, I think Dr. Sandra pretty much summed it up, except that the other thing that I can think of is that, we did touch upon it, that we have a very long international border, one of the longest borders in the country, and a very porous one per se. So, things up in terms of international health, because, even things which happens in the neighborhood, for example, Bangladesh or Myanmar, it is very easy for especially in terms of infectious diseases, for that to cross over. So, looking at it from that perspective, I think, we would, we have to be cautious as we're going forward, especially, for example, in terms of, let's say, the malaria. There's a lot of cases of malaria in our region in 2016, but now there is very few malaria cases. But then malaria is happening in other places, and it is very easy to have an imported malaria be imported into Meghalaya, the northeast region for that matter, because the climatic conditions are all there. So those are the things that can also impact how the health plays out.
And then kind of sticking on the theme of malaria and the advances that have been made in malaria control over the past few years, a speculative question to you both, in that, do you see the elimination of the threat of infectious diseases like malaria achievable in our lifetimes?
So I can only tell you from the evidence we have so far, I think Meghalaya has done phenomenally well in controlling malaria. In this year, from having so many deaths and myriad, thousands of cases every year, I think we just had one death is still one death, but this year we just had one death, and I think last year we didn't have any, and so the cases are certainly very low. We just have, when we started our center, there were several districts in which the annual parasite index was more than 1, but now we just have 1 district, and even that, the caseload is certainly decreasing. So everything going in the right direction. But malaria is a disease which can surprise us all. We had reached point of elimination some decades ago, and it came back. Evolution is not something we can mess around with, so we don't know. But I think Meghalaya is in the right path. We can at least see that it is a possibility that we could reach elimination. It is a possibility, definitely, and people have accepted that the insecticide treated bed nets very, very well. They are using it. The studies we have done shows that the acceptance rate is very high. They use it frequently. And after the free distribution of bed nets, which happened last year, 2020, people actually even take it to the fields, majority of them, some still don't. And that's probably where the place, the odd cases are going to come in through, like the international borders Rajiv mentioned, and the forest malaria. It's now no longer, I think, transmission happening in households. It's, I think, what is happening in the forests and fields.
Okay. And Rajiv, anything to add to that?
Yeah, no, I think what Dr. Sandra is quite true, that we have seen a dramatic decline in the cases, but there could be chances of importation, as we were discussing earlier, and there could also be chances of and I think I can already see a question about anti-malarial drug resistance, and that is something that we are interested in. We're going to look at it hopefully this year. We're going to do some studies looking at KDR resistance in the mosquitoes. So hopefully we'll have some answer. But those are the things that we need to be wary about. And also when there is so one of the things that we found in some of our regions, which was previously endemic but very little cases now, is that there are asymptomatic positives. For example, you have a PCR positive but negative by RDT or microscopy. So we need to think about how we are going to track the positives when the disease incidence is very low in a population. And those are the things that probably the better we are able to do it will probably help us in keeping our guard.
Very good. And moving on to a topic that both of you know is very close to my heart, international collaboration and reasons for doing it. So I'm interested to discuss with you how you feel that international collaborations can facilitate local capacity building. And we've seen some of, I think the slide that Sandra showed, particularly for researchers outside of that setting, to understand like the contextual barriers that there can be to conducting field work, like practical considerations of getting around access, etc. What would you say are the biggest challenges in conducting high quality research, be it expertise, financing, access, dissemination, etc.? So maybe we'll go to Sandra first.
I think you've already put those headings. All of those are challenges. When we talk about the Northeast region, there is need. There's a need for all that kind of subnational kind of research, because sometimes funding bodies want to do these multi-country, multi-state, and sometimes I wonder, but they don't answer the subnational level questions, the context-related questions. They certainly don't answer our regional and state level questions very well. Particularly when you look at the heterogeneity of India, the variation across the country. And often when you do these, when we see these big studies, they'll choose one big state, right? And then even in the national context, the smaller states tend to get just left out, saying, oh, let's go for the bigger states. But the smaller states, they're not small. They have significant numbers of population, and we need to address them in their own way. So yes, research is needed. Funding for them is needed. We do have a paucity of high-end researchers, who can draw in those grants. So our institution is very much focused on capacity building. For instance, when I first started the Regional Resource Hub for Health Economics, for the first few years, we advertised repeatedly and never got a single health economist from the region. So I went back to the ministry and said, you've got to change this. And be flexible. And they were, to their credit. And so we changed the parameters to say, we're just going to take young people with interest and aptitude, and we're going to groom them and make them the future health economists of the state and the region. And that's what we're doing now. We also enroll them into PhD programs and help them learn as they go, as they work, and become the leaders. So as far as international collaborators, yes, we do need mentors. We need funding. We need we'd love for you people like yourself to come over and have time for us. We can't afford Oxford rates, unfortunately. That's where the funding comes in, I guess. So we need to find solutions for all this. I probably should stop there, and maybe I'll allow Rajiv to chip in here.
Yeah, no, thank you. I think it is very important. I mean, I can only say for myself, because what I am today is because of what my mentor had in terms of international collaborations. I was a trainee of what is called as a Global Infectious Disease Research Grant, which is funded by the Fogarty NIH, which gave me opportunity to go and spend 6 months initially in the US at Tufts University learning epidemiology and statistics, and then I was able to go back there multiple times because of my fellowship, the early career fellowship that I had from the DVD Wellcome Trust India Alliance. I was able to spend a year at Imperial with a very known group of modelers there to learn about modeling and disease modeling and things like that. So it is really important because it gives a person as an individual a perspective, a global perspective, which is really helpful to know what are the challenges in other places and to interact. But it also gives a platform to collaborate and discuss, because many of the big research institutions like Oxford is also a global melting pot where people from different cultures, different societies, different countries come together, and there's always a learning. As Professor Sandra mentioned, that in IPA Shillong we are actively trying to promote this kind of learning. In fact, one of our junior colleagues, Uniki Mori, is actually doing her PhD in epidemiology at the London School of Hygiene and Tropical Medicine. She was able to get a Travels Fellowship to be able to do that. But I think that is fantastic, and we would definitely look forward to collaborations with institutions like Oxford, for us to also learn. Also, what is important, as Dr. Sandra again mentioned, is something about putting things in the local context. And again, to kind of take an example, very recently, both me and Professor Sandra was in a meeting of dengue awareness, but the theme was global problems, local solutions. And that is so important because, sometimes we think that one size fits all approach is all that will work. But that is nothing true in public health, because of all the things that we listed up, we have been listing in terms of the uniqueness of the Northeast, for example, the regional challenges, the challenges in health systems, the different disease profile, the cultural profile. All these would require us to develop local solutions, even though the problem is global. And I think working together with international collaborators, harnessing each other's strengths to move forward with that would be wonderful. And that would also, I think that international collaboration is always a two-way street, which a lot of time we tend to forget. Because, as our students could go and probably, if you have a student exchange program, go and learn from the best in the UK or US for that matter, the students from Oxford who are doing international studies also could come and would see a totally different perspective, which is not something that one would normally get in their own countries. So I think that is where I at least look at international collaborations.
I can agree with that more. I think the sort of bi-directional aspect of learning is so important and often not emphasized enough. Yeah. And as you both know, I spent time working in India and learning, and what I learned from that sort of situational work is unrivaled. And so, you can read whatever you want, but it's not the same as being there. We've got sorry, Sandra.
So I was also going to add that we are not interested in the kind of research or institutions who see us just as data collecting agencies. Yeah, we simply do not want to do that kind of. I refuse. I'm constantly reached out for what equates essentially to just collecting some data for us and sending it elsewhere, and I refuse to do that. I said no. If there is no capacity building element in this, where we are equal partners, we are simply not interested. We don't have the time for this. So that's something which is very close to all my faculty and my team, and we think of it. We feel strongly about it. Rather,
I think that's
it should be equal.
Absolutely right, and I think that old model of what was considered global health research is no longer relevant in the modern times. We've got some questions in the Q&A. So couple of questions from Sarah Lewington, who you'll remember from the grant last year. So Sarah asks, on capacity building, have you been able to establish exchange schemes with any of your international collaborators?
No, I wouldn't say there's no formal exchange. We, for instance, Unique is now, like Rajiv said, she's a PhD scholar at the London School of Hygiene and Tropical Medicine. That's because we found funding for her from a tribal scholarship to go there and spend the time. Through our malaria research, people have been going for short conferences and a little bit of exposure, but I don't think anything much more formal than that has been. It's something that we are certainly interested in, both for our faculty and for the young researchers, more for them actually. One of our postdocs has just applied for an early career fellowship where we are trying to build in some of these sometimes spent at Manchester and other places, for instance. So yeah, we're exploring all this, but I don't think we have a single program which has made it all very systematic and routine.
Yeah. I mean, I think all of Sarah's questions, I think, have a very personal point to her. And her second question is about, given the diversity of the population, the Northeast region would be the question's just gone. It's here. Would be an exciting area to establish a large-scale blood-based epidemiological study. Is this something you have ever considered? And if so, what are the challenges of establishing the study and the possibility for long-term follow-up? And I suspect Sarah would also like to ask whether she could be involved in doing that.
Certainly, it is very much in our. We have actually drawn up some plans. We are talking to the Principal Secretary Health. We started off wondering whether it should be a pregnancy and birth cohort kind of one, but now we, I think, moving towards a demographic and surveillance kind of large cohort. So it is on the anvil, definitely. I think it will come soon.
And what are the mechanisms for follow-up that are being considered? Are they now much more possible with the digitization of the sort of healthcare systems, or is it still going to be a paper-based, having to go around, route survey, etc.?
So the thing is, although in our malaria and other, even our zoonotic vector-borne disease, we have tablets, we will take it around, but the reality is our team always has to have the backup questionnaires with them, which is pen and paper, and they may have to come to the lab and then enter it again. So while we are hopeful of connectivity being established, and often the worst connectivity is in the places where the need is the most, right? So while we are hopeful that connectivity situation will improve, it is nowhere near perfect.
Right.
Rajiv, for instance, is sitting in is right now in the city of Shillong, which is supposedly the best connective, and you just saw how bad that could get. When we have storms and rains, everything can go for a toss for a while, and then it comes back. But yeah, so that is definitely a challenge. Rajiv, do you want to add anything there?
Yeah, sure. I think you're very right when you say, when you talk about the challenges, because when we talk about setting up in any kind of and I think what Sarah is actually hinting towards is some sort of a biorepository. When you're thinking about that, of course, the challenge is when the logistics is one part of it for sure, because, we have to collect the samples from the field, then the samples has to be transported, and then the samples has to be stored in a central repository, and we have to ensure that the data flow as well as the sample flow is as complete as possible to get good sample. That is one. And the other thing, of course, is the fact that, how we ensure that the metadata is linked and is de-anonymized, because that is another issue with these kind of things. So we are working towards that, and as Professor Sandra was mentioning, the zoonotic and vector-borne disease is something that we are hoping we'll be able to start developing that biorepository in a small way and hopefully expand on it more and more. On that, the sero survey that I mentioned, the sero survey that we did as the facility-based sero survey that we did for the COVID, unfortunately, we are not able to store the sample. Otherwise, that would have been really valuable samples, because that is over 5,000 individuals, which was an age structure sampling approach where we would have got the data. But we are moving towards it. The other thing is that we really hope, and we talked about the zoonotic, and I just briefly touched upon the Zoonotic and Vector-Borne Disease Center, but they did not really elaborate on the research plans. The plan is to set up a concurrent human and animal surveillance system and overlay it with the environmental data over a period of 3 to 4 years. But what we are really hoping from this entire exercise is that it is not going to be a one-off one-off effort, but it's going to expand, and it's going to, we can use it as a platform for other studies, and it need not be again studies only on infectious diseases, because we'll have a longitudinal surveillance data from about 40, 30 households per village, is about 900 households also. So we could then, if we get future funding, we can then expand on it, and definitely expand on the ambit in terms of the area. So yes, I think we would be very much interested to talk to Sarah if she is interested in setting that kind of a system, because I think that is.
I think I can answer on her behalf and say that she and I would both be interested in working with you on that. Yeah, she's put yes, please in the chat. So a couple of other questions have come up. So first one, thank you for the great presentations and very interesting to hear about this work. Following on from the latest question, which was about international collaboration, I wondered what the regulatory challenges are to establishing international collaborations in the Northeast region and in India more broadly. Any thoughts?
So the regular, well, for any health foreign funded grants, we have to go through something called the Health Ministry Screening Committee, which is a process and sometimes a little time consuming, but it's getting better these days. You've got to submit it, and it is vetted by the Indian Council of Medical Research, the committee set up by them. And then, so I guess, in terms of once you set it up, it's again, the Indian government is very particular that samples don't indiscriminately leave the country. So you are usually expected to sign a material transfer agreement, by which you commit that you will not send anything more than the maximum is 10% of the samples that you collect. So that's something so in other words, what we do for our malaria and research is that, if there is quality control or systems and processes to be set up, so up to 10% of can go to our collaborators, but otherwise much of it, almost all of it, stays in India, and capacity building happens here so that we do the work in India itself. Other than that, in the Northeast, yes, you cannot come in as a entity and just start, where you will certainly have to work with the local institution. Even us, we work with the formula that we don't just allow even any intern or junior researcher who comes to our institution to just go into the field. Yeah. I always say that you are not ready for it. We will always make them accompany a research assistant who's bilingual, who knows the language, who is an indigenous person themselves, who will create the rapport with the communities. And so we have traditional governance institutions. So even though ethics committees are only bothered about individual consent, we go through an additional layer of consenting. We first go and explain it to the headmen. We will hold a community awareness program in which we have to tell the community what this is all about. And then you go ahead and do the usual about individual consent and household consent and so on and so forth. So those are kind of the things I can think of. Anything else, Rajiv? Am I missing anything?
No, I think that is pretty much it. So we have to take into account the community sensitivities in doing research.
Rajiv, we're struggling to hear you a little bit.
Sorry, I'm taking into account the community sensitivities while doing into research, because we live in a more close-knit community, and it is not only Northeast. I think it is India in general when I'm saying this, and so it is usually expected that we are going to work with the community rather than a more individualized approach that is what is normally done in international research.
Okay. And then we have another question here. Thank you for the overview of the work done at IIPH. A question for Professor Albert. Did the malaria surveys include assessments of genetic markers of anti-malarial drug resistance? And if yes, have the results been published or are they otherwise available?
No, so that's something we're going to do this year. So we have there's a biorepository, and a lot of the samples we collected are in our deep freezers. And this year we're going to do the KDR, and other studies are going to be planned. So that's something that's on the cards, not done as yet. We hesitated in the beginning because initially we had these big plans of doing even the mosquito resistance, but then we the challenge in the field was getting the numbers of mosquitoes that we needed for the mosquito-resistant tests that WHO recommends. So now we're moving into the molecular level kind of tests. And yes, so that's on the cards, and we'll hopefully you'll see something from us.
So I think that answers Mehul's question. Then we've got a question in the chat. It's been really interesting to hear about environmental and practical challenges of working in the Northeast states. What about institutional challenges? I think we've covered quite a lot of this. What about institutional challenges working between a center, institutions in the Northeast states, especially for collaborations, health priorities, research priorities? I think we've covered quite a lot of that in terms of the challenges. Are there any other thoughts that you have when I think this is about about bilateral research. I feel like we've probably discussed that. I'm just seeing if there's any more questions in the chat. I think that looks, question from the YouTube channel. Rajiv briefly mentioned about research in animal disease sector and One Health. Are there any active activities, collaborations in this area?
So as I mentioned about the One Health Center, the Zoonotic and Vector-Borne Disease Research Center, which uses a One Health focus, and this is in collaboration with the Indian Council of Agricultural Research Northeast region. So we have a veterinarian that we are working with in close collaboration with for that. Other than that, we are actually also looking at other aspects of One Health, and we are very open to ideas on One Health for now. We recently put in a grant with our colleagues at Christian Medical College Fellow looking at human-animal transmission of helminth infections, because that is another field where there's a lot that is done. There are periodic dewormings that is being done by the WHO with generous drug donations from pharmaceutical companies, but and a lot of modeling and other things done. And but largely the studies has been centered around the humans. But we know that there are certain zoonotic species of helminth which is circulating, and there's the dogs and cats especially are also mechanical transmitters. So we have put in a funding for that, and we are hopeful that we'll get funded, but let's see.
Okay, so I think this has been a really great discussion and lovely to hear about the breadth and the scope of the work that's going on at IIPH. And I think we can also say that if there are people who have been listening that would be interested in collaborating potentially with Sandra and Rajiv, that if they contact Marwa, she can put them in touch with the center and they can take those discussions forward. And I'd like to thank Sandra and Rajiv very much for your time and your generosity. And it's been a really, really good discussion. So thank you very much, everybody.
Thank you.
Thank you, Toral. Thank you for having us.
Thank you.